So the speakers for this session were chosen from a public comment opportunity that the committee held, so we could hear from any member of the public who would like to contribute to our work. We asked individuals and organizations to provide their thoughts on how they personally identify and how these identities and population descriptors should or should not be incorporated into genomics research. We heard from a wide range of respondents, including researchers, clinicians, patients, and government representatives, research funders, publishers, industry. Thanks to everyone who submitted comments. So we assure you that we do read each and every comment that was submitted. For this session, we're going to hear from several respondents, and each person will speak for 5 minutes and give comments. And these respondents are from a variety of stakeholder groups. So I'm going to go ahead and introduce our first speaker. Our first speaker is Jennifer Webster. She's Senior Director of Precision Medicine and Real World Evidence Lead at Pfizer. Go ahead, Jennifer.
Thank you all so much for the opportunity to speak today. I really appreciate the invitation. I'm speaking today drawing on my own experiences working in health IT for a number of years, trying to deliver various precision medicine applications across a number of community providers, particularly in oncology, and then also the work that I do now at Pfizer, where we're trying to use real-world data to drive our precision medicine strategies across drug discovery, development, and deployment. My views today are my own. They do not reflect my current or former employers. I wanted to take a chance to echo a lot of the calls that I've heard in the previous version of this workshop in March, and also today, for us to really think hard about limiting our use of self-reported race and ethnicity data across the various applications that we're trying to deploy in this space. I want to focus on 2 points that I haven't heard raised consistently that really draw from my experience of trying to deliver real-world evidence solutions to patients at scale. So we talk a lot about translational research, taking things from the bench side to the bedside. I think a lot about transformational research. A lot of the solutions that I've worked on really benefit community providers, benefit patients receiving care in the community, not at big academic centers, sometimes at very small oncology practices. And we want to make sure that we're developing solutions that work for those patients in the real world, so that we're not inadvertently creating extra health disparities. One of the other points that I also want to make about why I think the perspective of people both generating and using real world data, and we've heard a few others today, is so important, is that we've now reached a turning point where we are generating more genetics data through real world care than we are through research. And increasingly, as that volume continues to grow, we are going to continue to be enticed to do research on that real world data. And so taking into account the place where that data was generated, how it came to be, I think is really important. So the 2 lenses I'd like to add to this conversation are around privacy and security. And from a privacy perspective, because I've developed a lot of regulated health IT applications, I think a lot about both HIPAA and GDPR, which encourage us to really use minimum necessary data to answer all of our research questions. And there hasn't been a lot of regulation, in particular in the US, for HIPAA around kind of enforcing these minimum necessary standards. But we do expect to see that level of enforcement grow over time. And one of the places that I anticipate us starting to see that is potentially around these self-reported race and ethnicity categories, in particular because in our real-world data sources, we see that between 25 and 40% of our patients tell us that they would prefer not to tell us their race or ethnicity. That to them is sensitive enough data that they don't want their doctors to have it. And that matters to us from a privacy perspective. It also matters to us from an implementation perspective. If you're planning to develop a polygenic risk score that becomes more accurate when you add in that self-reported race data, it's possible that that score isn't going to work as well for those 25 to 40% of patients who don't actually want to report their race data to us. It also, as we just discussed in the last presentation, makes it much harder for us to port that data outside, or that score outside of the US, where all of those markers have changed. So in the cases where we can develop more genetically based similarity scores, as I think was raised earlier, that would be easier to scale, makes this a lot easier for us to globalize good healthcare decisions. The last piece I want to talk about is security. I think people don't necessarily think about data security, particularly when they're doing research, but in 2020, just in the US, 34 million patients had their healthcare records breached. That number went up to 45 million in 2021. So we're looking at a situation where 10 to 15% of health records every year are breached. And so you have to assume the data you are collecting at some point may end up implicated in a breach. So what we collect, we really have to protect. The sensitivity of some of this data may not seem particularly sensitive if you're not in a group that has historically been marginalized, but I think a lot about what I would be doing right now if I was sitting on a data set that included information about, for example, Ukrainian patients in Russia, or possibly children in Texas who identified as trans. So I'll stop there. Thank you so much for the opportunity to speak.
All right, great. Thank you so much, Jennifer.